MCC HBCH to give a talk on a perspective from Prostate trial for oligometastatic prostate cancer. Dr. Prashanth.
Good morning. So my presentation will be short and sweet, I hope. So Dr. Lincoln has basically presented where all SBRT can be done. So I'll be basically presenting a new part, which is low volume metastatic prostate cancer. So as already mentioned, with more sensitive images with PSMA PET, we are picking up more metastasis. And therefore, and presently the standard of care for all de novo metastatic prostate cancer is androgen deprivation therapy, either medical or surgical, with addition of docetaxel, abiraterone, or enzalutamide. We have level 1 evidence for that. Now, metastatic prostate cancer, based on the charted and the latitude criteria, can be divided into low volume or high volume disease. So low volume disease or low risk disease, as we can say, C basically includes up to 4 bone metastasis and in the absence of visceral metastasis. This is the general definition of low volume versus high volume metastatic prostate cancer. So what is the difference in the management of low volume metastatic prostate cancer? So the Stampede trial, which was a trial having 17 arms, also had an arm which randomized over 2,000 patients into the ADT alone arm versus ADT plus radiotherapy to the prostate. So when the outcome was assessed in the low volume disease or the low risk disease, that is patients with less than 4 bone metastasis, what was found was both overall survival as well as failure-free survival was significantly improved with addition of radiation to the prostate in the low volume subgroup. So subsequently, there was a meta-analysis also done in this group. And what was found was the 3-year survival was increased by 7% in patients who received radiation to the prostate for 4 bone metastasis or less than 4 bone metastasis. So what's different between high volume metastatic prostate cancer and low volume? Basically that ADT plus abiraterone enzalutamide docetaxel should be combined with radiation to the prostate. So is there a role of radiation to the metastasis in low volume prostate cancer? So as of today, we do not have any evidence for improvement in survival when SBRT is given to all the metastatic sites in low volume metastatic prostate cancer. So we need to look at the results of few studies that have come up, that is Saber, Comet, Oriole, and the Storm trial. So in the Saber Comet trial, it was a basket trial which included a lot of sites. It included breast, prostate, colorectal, and as well as lung. It was a phase 2 randomized international study. So the patient population was basically 1 to 5 metastasis and a controlled primary tumor. All the metastatic lesions had to be eligible for SBRT. So what was the intervention versus the comparator? So the standard arm was considered to be standard of care systemic therapy with addition of palliative radiation if there was pain. The comparator arm, that is the intervention arm, was SABR to all the metastasis. So what was the primary endpoint? It was overall survival. So 99 patients were randomized. As you can see, it included patients of breast cancers, lung, colorectal, and prostate. So what we had was a 5-year survival. It was improved by over 20% on addition of radiation to all the subsites, all the metastatic sites. So after the Saber Comet trial, we also had a Storm trial and Oriole trial. These basically included only patients of prostate cancer. So this again was a multi-center randomized phase 2 study. Now look at the population that was included. It included asymptomatic patients who had a biochemical recurrence after primary prostate cancer treatment. So they did not include de novo metastatic patients, but included patients who had been treated initially either with surgery or ADT plus RT. And after that, when they progressed, these were randomized into this trial. So what was the basic comparison between? It was between metastasis-directed therapy, which included surgery to all metastasis or radiation to all sites, that is SBRT to all sites, versus surveillance. And the endpoint was interesting, that it was androgen deprivation therapy free interval. So it randomized 62 patients, And at a median follow-up of 3 years, what they found was ADT-free survival increased from 13 months to 21 months when we used SBRT to all metastases. So patients can be spared ADT for almost 1 year extra. A similar trial was the Oriole trial, which was again a multi-center randomized phase 2 study. The patient population was the same, that is asymptomatic biochemical recurrence after primary prostate cancer treatment. The intervention includes surveillance versus metastasis-directed treatment, that is SBRT. So the primary endpoint was progression-free survival. So as you can see, the progression-free survival at 6 months was significantly lower when SBRT was given to all the sites. So the value was 19% versus 61%. So from these trials, what we can infer is that probably SBRT given to all metastases in oligometastatic prostate cancer would be effective in delaying progression and probably in delaying start of ADT. So the problem with the above trials were, one, some of them were basket trials, and second, they were used in the evaluation of only relapsed patients. So there was no evidence in form of RCTs for management of de novo metastatic low volume prostate cancers. So we launched a phase 2 RCT for this subgroup of patients. So that is the prostate oligometastasis trial or the PROS-O trial. So it is an open label phase 2 randomized trial. It basically includes de novo metastatic prostate cancer patients up to 5 metastases. The comparators are standard of care arm is ADT in the form of surgery or in the form of leuprolide or androgen deprivation, any other form, along with abiraterone or enzalutamide or docetaxel. The comparison is between palliative radiation if there is pain versus SBRT to all metastatic sites. The primary endpoint is 12-month PFS. PFS includes both clinical as well as biochemical progression. The target recruitment is 40 in 2 years. The status is presently actively recruiting. So what were the inclusion criteria? So the important point is that we have taken up to 5 asymptomatic or mildly symptomatic metastases. This includes all metastatic sites. It could be bone or soft tissue or lung or liver, but all these sites should be amenable to SBRT. Patient must not have had their primary tumor treated with radiation. Both hormone sensitive as well as castration resistant prostate cancer may be included. In the exclusion criteria, any lesion that is not amenable for SBRT would be excluded. Patients who have severe urinary symptoms upfront, that is an IPSS score of more than 20, will also be excluded. Now, as far as the recruitment status is concerned, the accrual is as of now slower than expected. We expected that in 2 years we would recruit 40. In the last 12 months, we have screened 29. Only 11 were found eligible and were randomized. 9 have completed treatment, are on follow-up. So the reasons that we found for slow accrual were, one is the suitable patient population is very small. Second is all the lesions are not suitable for an SBRT. That is, there are lesions in the ribs which may not be targeted, paratic nodes near the renal parenchyma, paratracheal nodes. These are probably not suitable for SBRT. And another problem was that a lot of our patients who had oligometastatic disease presented with severe urinary symptoms. That is, these were patients who had had acute urinary obstruction, and therefore they were catheterized, so high IPSS score, and therefore they were excluded from recruitment. And another problem is that it is a single center accrual, therefore the recruitment status is quite low. So what are we trying to prove or disprove with this trial? So we are just looking at if the recruitment completes and shows benefit. A phase 3 trial can be launched to create level 1 evidence for addition of metastasis-directed therapy in de novo low-volume metastatic prostate cancers, along with the standard of care, that is ADT plus abiraterone or enzalutamide or docetaxel. And subsequently, we may also run trials which can compare metastasis-directed therapy with RT versus the standard of care and keeping ADT-free interval as the survival endpoint. We would definitely have funding issues in such trials, but the expected use of this trial is that these trials may help delay the start of systemic treatment in this subgroup of patients, low volume metastatic prostate cancer, who have been diagnosed with PSMA PET-CT, and therefore provide an extra treatment modality in metastatic prostate cancer. So what other trials should we watch out for? We have the Extend phase 2 trial, which has been published recently in JAMA Oncology. This trial was also similar to what the PROSO is. It is comparing ADT versus ADT plus prostate and RT to all sites. Now, in this trial, 87 were randomized. The PFS, there was significant PFS benefit. In the experimental arm, it was not reached, versus the standard arm, it was 15.8 months. The issue with this was that systemic therapy in this trial included only 6 months of ADT versus continuous ADT that we actually consider standard of care. So, thank you.
Thank you, Dr. Prashanth, for excellent presentation. Any questions from the audience? I joined just.
Yes.
I just, what is the end point of that study?
This is 12-month PFS, sir. So basically, we are looking at, it's a phase 2 RCT. We are looking at metastasis directed therapy along with prostate RT in low volume metastatic prostate cancers.
And the Abertron and Enja, as per
that is standard of care.
So one arm will be